Welcome to podcast 9.
I'm Fran.
And I'm Minnie.
And as always, thank you so much for your feedback. It's incredibly useful. Please keep giving it.
Thanks, Fran. So this podcast topic is on eczema. And our tip today is use our dermatology specialist with your skin problems. And we will attach at the end a guide to common skin diseases in Africa for you to use and help you with your cases.
Brilliant. So why are we talking about eczema? Well, it's incredibly common, particularly in children. And in fact, my son Walter presented with eczema when he was age 2. And despite being a GP and thinking I knew what I was doing, actually, I really struggled to control it. So, Minnie, what is eczema?
So the definition for atopic eczema is a chronic relapsing inflammatory skin condition which is characterised by an itchy red rash, and it favours the skin creases, so around the elbows, behind the knees, as places where it's often worse.
Okay.
Can you tell us a bit about the cause of it, Fran?
Yeah, so it's thought to be 2 causes. So there's a genetic cause, and it tends to run in families who have what's called an atopic tendency. So they have this, they have the eczema, asthma, hay fever, and allergic rhinitis. Mm-hmm. So interestingly, neither me nor my husband have atopy, and other than Walt's grandfather who has some eczema, we don't have any family history of this. And then the other reason is environmental. So it's thought to be a primary defect in the skin barrier function, which causes the actual rash to develop.
Okay. And have you noticed with Walt that there are any particular triggers for his eczema, if we think about that?
Yeah, so things that we know can trigger it. So soaps and detergents. Well, I was aware of this. So in fact, I'd been washing him with an emollient since birth. Overheating can, and certainly his started in winter. And rough clothing that sort of rubs against the skin can also do it. Skin infections, animal dander. Well, we do have a dog who occasionally howls in the background in podcasts, so some of you may have heard him. Aeroallergens. This is the proper way of saying pollen. So when you're allergic to, certain trees or plants in pollens.
So that would suggest that it's particular times of year when your eczema may be worse, if that's your trigger.
Absolutely, yeah, and it's very true for people who have atopy as well, that their hay fever coincides with particular plants. Mm-hmm. So they can say, look, I know I only get it in this season when rapeseed, for example, I know I'm allergic to rapeseed and I only get unwell, with eczema or hay fever or allergic rhinitis during that season.
Okay.
Interestingly, they talk about food. So my understanding was that food actually wasn't a trigger very often. We do know that children who have a lot of allergies, so those that have egg and milk, proper allergies, that they do sometimes have eczema. But eczema is
rare, isn't it?
Yeah, but eczema is so common that actually it's not advice that I would ever give to someone to avoid food unless they were having a clear allergy, they were having lip swelling or a rash after eating something. And in fact, with Walter, I breastfed him for 9 months. So, and that's
reduces
protective,
the risk anyway, doesn't it? Yeah.
Exactly, yeah. House dust mites, well, I live in a house with a carpet, so I am sure we have a million house dust mites, so I'm not even going to worry about that. And stress. Well, I'm kind of hoping 2-year-old Walter wasn't particularly stressed, but who knows?
Yeah. Well, those are all important factors to think about anyway. So if we think about the history of eczema, we find that it frequently presents in childhood, don't we? So about 20% of children, certainly in developed countries, will develop it during their childhood. But it can present at any age, and I think that's important to note, isn't it?
Yeah, absolutely. And the article I read, I think they didn't have clear stats on eczema in the developing countries, but they felt it was probably very similar. Mm-hmm. Yeah. Okay. So it tends to present, well, we said typically in the flexures of your elbows and knees, but actually it can come all over the body. And and if you've had eczema for a long time, the scratching that you're tempted to do because it's so itchy actually alters how it looks, and where you get it will also vary with age. You have a tendency to dry skin which persists through life, and then you get these acute. So you get so the trouble with eczema, which you commented on, Minnie, was that you get these. It's a lifelong and it's a relapsing condition. So you get these acute flare-ups, and they can vary quite a lot. So you can get little vesicles, so sort of fluid-filled things, to areas where it's just very red with no clear, what we call demarcation, so sort of no clear outline around it. You can also get crusting, scaling, cracking and swelling of the skin.
So it can look like lots of other skin conditions then?
Yeah, it can do, actually. Yeah, it really can do. And that can sometimes be a little bit tricky. So in Walt's case, initially when he was 2, it was a problem in that and it was very obviously eczema then. It was very much in the flexures of his elbows. But interestingly, now he's got older, what appears to happen is his skin looks completely intact, but it's obviously, so he doesn't have any rash there at all, and then something will trigger it and he will obviously become itchy and he will just scratch his skin, and it's at night only, and it's in the areas that he can access around his pajamas. So it's around his ankles and around his wrists that he just scratches in his sleep without realizing. And it doesn't look like classic eczema. It looks just much more like scratch marks, to the point that my husband said, "Are you sure this is eczema? Because it doesn't look the same." So, like you say, it can look like a lot of different things.
And obviously, the scratching actually changes the way the skin looks anyway. So repeated scratching will give you that sort of thickening of the skin anyway. So the appearance starts to change with time.
Yeah, and that thickening is called lichenification, and that's what you get. And I think that the pamphlet the guide that you talked about has some nice photos of that. So like we said, so normally in infancy, it's normally on the face, the scalp, and on the limbs, and normally the nappy area is spared. But then as you get older, it can vary, and in darker skin, you get a lot of follicle involvement. So again, it can look slightly different, a bit more like a folliculitis.
So hopefully there are some nice pictures of that in the guide, Fran.
Yeah, there are, and I think one of the things that is interesting is how different rashes can look on different coloured skin. So you just have to sort of keep an open mind as to what things can be.
So other things in the presentation to look out for that might suggest infection, that's something else that will, again, change the appearance of the rash. So if there's a bacterial infection, what we'll be looking for there, would you say?
So you tend to get sort of crusting, weeping, sort of pustules, or even some sort of cellulitis around the skin, or a sudden worsening of the condition. And in fact, sometimes if you have very bad eczema and it's not responding to treatment, I was taught that, if it's not responding to treatment, consider whether there's an infection there. And certainly I've had experience with patients where I haven't thought, looking at it, that it's been obviously infected. But like I say, it didn't respond to treatment, gave some antibiotics, and it got much better. Yeah. And then tell us about eczema hepaticum, Minnie.
So this is suggested when you get a rapidly worsening and painful area of your eczema, excuse me, and you may get clusters of blisters, which look quite like those that you see with the early stages of cold sores, sort of the ones that you get around your mouth. So it's a punched out erosion. It's a circular lesion with some depression and ulceration, and they're usually between 1 to 3 millimeters and all look very similar, so they're quite uniform in appearance. But in a large area, they may all start to merge together, coalesce, and you may get some crusting. Quite often, your patient will be quite unwell in themselves as well if they have eczema hepaticum, which is a viral infection on top. And they may have a fever and be quite distressed. So you should really treat them with an antiviral medication. And certainly here you'd probably admit them, wouldn't you?
Absolutely, yeah, because it's considered to be a life threat. There aren't very many life-threatening dermatological conditions, and that's one of them. So I would always be admitting someone. I mean, we don't see it very often in the UK,
No.
but you would definitely admit them. So then thinking about differential diagnoses, well, so things that can present very similarly are psoriasis, contact dermatitis, seborrheic dermatitis, fungal infections, and just be a little bit wary if you think it might be a fungus, not to use a steroid on its own, because if there's any fungal infection there, the steroid will push the fungus further into the skin, making it harder to treat. Scabies, it could be that, or other infestations, and lichen simplex chronicus, which isn't something I know very much about, if I'm honest. But actually, it is a clinical diagnosis. We don't do tests on it in the UK. You see someone, you think that's what it is, and you treat it.
Yeah. And then obviously if it gets better, you're making the right diagnosis. I think the one thing that is really important is the crossover with fungal infections. So that's the one thing that you need to really be wary about, don't you? Because of the treatment, which we'll move on to now.
Yeah. So the management of it. So the mainstay for anyone with eczema is emollients. So these are, I know that in Zambia you have aqueous cream. We've moved away from that in the UK, but it's that range of creams, ointments that you use as moisturizers. And there's an awful lot of evidence that the more you use them, the less likely you are to have a flare and the less topical steroids you're going to need.
And so that's using them all the time, even when you haven't got a flare-up.
Yeah, and if I'm honest, that's something that I'm really bad at doing with my son Walter, which is why he now has this terrible scratch marks around his ankles and wrists, because when his skin is good, it doesn't look particularly dry, and it goes out of my head to moisturize him, and he doesn't particularly like being moisturized.
Okay.
And I think the most important factor, because in the UK there's a massive range of different ones that you can use, but the most important one is the one that the patient will use. So it doesn't matter which one it is.
Yeah.
There's no point having a great one if it's just in their cupboard. Ointments tend to be less well tolerated by patients.
They're quite greasy,
because they're very
they?
greasy, yeah, but they're less likely to cause allergies because they don't have preservatives in them. And what I tend to do is, so babies don't mind because obviously they can't complain, but for patients with bad eczema, I say use that at night and then a less greasy one in the day. If you prefer, and that's what I'm trying to do with my son at the moment. Yeah.
So how do we go about putting them on?
So loads. So you need loads of them. So it's large quantities. So if you've got bad eczema, you should be using 500 grams a week for an adult, which is a huge amount. I've got tubs in my cupboard that going back a few years, and half of that, 250 for a child. And with all topical treatments, they should be rubbed into the skin until you can't see them, and they need to be applied downward in the direction of the hairs, because if you go upwards, you're at risk of giving folliculitis.
That's a really good tip, actually.
Yeah, and I think the other thing that I was doing, so in the end with Walter, when he was 2, we ended up seeing an eczema specialist nurse, was I was putting too much on, and actually that's detrimental because it then kind of clogs up the pores. So it is just a thin layer that you need to be putting on.
But regularly.
But regularly, and you do need to tell people that they can sting for the first couple of days before they start soothing the skin, and that's a complaint I get quite a lot.
Well, that's good to know. So they need to bear with it. And
they do, and people don't because they get frustrated.
Yeah.
Ointments, which we're talking about, they tend to come in tubs, and so the advice is not to put your hand in and scoop it out by hand, because if there's infection, you're going to contaminate it. So you should be using a spoon or something. And if I'm honest, I don't. But that is the advice we should be following. Sorry, and giving to patients. And then you have ones that have so you have emollients that have different things in it. So there's in the UK we have something called Dermal 500 that has some antiseptic. So if someone's getting lots of flares, you could use that. If someone's getting very itchy skin, you can give an emollient that has an antipyretic, so an anti-itch property, such as Balneum Plus. And the advice is that you should also be using it as soap, although there's not so much evidence as to whether that makes a massive difference. We do know that soap dries the skin, so
Yeah.
they should be using the same emollient to wash with as a soap. And then finally with them, it's just to say that if you're using a steroid as well, you put the emollient on first, let it sink in for 15 to 20 minutes, then apply the topical steroid.
Okay.
Now, I have a feeling that the advice used to be the other way around.
Well,
But anyway.
I was just going to say that I remember very much the advice being contrary to that. So you put the
Yeah.
steroid on again, but I think it's probably important that you leave time between the application of the two different creams. That's probably the crucial
Yeah.
thing.
Yeah, and I think the thing that interests me about it is, it's not a massive amount of time, but actually if you're trying to get out to work and you've got your kids going to school, actually it's incredibly time consuming to remember to put cream on, leave it for 20 minutes, put another one on, let that soak in, and then get your child dressed. And, if they've got very bad eczema and you're moisturising them 4 times a day, it's actually a lot of work.
Yeah.
So I'm a lot more sympathetic to people who aren't doing it terribly well than I used to be. So that's our sort of maintenance. And what do we do if there's a flare up,
So
Millie?
if there's a flare up, it's the same in both children and adults. It seems the advice is that it's best to give a hard hit with a potent steroid rather than just for a few days, rather than using a less potent one for a longer time. That's certainly very much the advice.
Yeah, and I think that's something I've changed in my practice, and I think historically GPs in the UK have been very nervous about using stronger steroids and have tended to use sort of hydrocortisone, which is the weakest one for long periods of time. So I was quite interested. They said, so for a child's face, you should use hydrocortisone. For their trunk and limbs, you should be using something stronger. So in the UK, we would use Umavate or lower strength Betnavate. And then in adults, you should be using that Umavate on the face, which isn't something I've seen that coming from dermatology clinic, but I've never felt confident to do that. But I think I'm going to change my practice.
I guess if you give very good advice on the length of time to use that treatment, then that's the important thing. Not just giving someone some steroids and letting them use it willy nilly. They need to know how long and how often.
Yes, well, and I think that's that. And actually, I'm not sure we talk about it here, but the one thing that I tell parents, because it's something I didn't do, which is why Walter's kept rebounding. So one, I wasn't very consistent about using the steroid because of working. I had different people getting him dressed in the morning, and sometimes I'd be there, and then sometimes I wasn't, and it wasn't consistent whose role it was. So we made it very clear that one person was in charge of creaming Walter, for want of a better word. And the other thing was I wasn't very good at weaning the steroid off. So what I would do is I would use the hydrocortisone, notice it got better, stop it immediately. And you get a rebound if you do that. So actually always when you're using even hydrocortisone, you need to be weaning it down. So you go from twice a day to once a day. If it's fine, you go to alternate days, and then every third day. And then by then you've sort of forgotten anyway. So that's fine.
Okay.
Yeah. So guys, have a look at the transcript, because it's got information on there about which steroid you need for which area, and that's really helpful. And places like the palms and soles, because the skin is really thick, you need to be using a very potent steroid, something like Dermavate. Yep.
Okay. So we need to think about bacterial infections as well, because and how we treat those.
Yep.
Because although the emollients, some of them do have some antiseptic added, they're not there to prevent infection or to treat infection.
Absolutely.
So you may need to treat if it like you said, if things are not improving, even if it doesn't look infected, or it does look infected, then you need to start treating with some oral antibiotics, and usually a 14-day course should be given. So
I didn't realise that. It is quite a long course. I've only ever given 7 days, but I'm going to change my practice now, because I think I've noticed that they're not always quite clear after 7 days. So there you are. Learn and live.
And so would you usually prescribe flucloxacillin as the most common cause of B. staph aureus?
So in adults I always do. In children, I would quite often use erythromycin, because the formula for Fluclox is so disgusting that almost no child will take it. It's just a complete waste. I don't tend to swab, although interestingly, they say that, if it's not settling, to swab, but I can't remember the last time I did a skin swab on eczema. I think it normally just got better with flu clots.
Okay.
Yeah, and then you can do these steroid antibiotic combinations. So fusidin with hydrocortisone or with betnavate.
So a topical application.
Yeah, topical application, and I sometimes use those, although you're not supposed to use them for any sort of prolonged time because of antibiotic resistance. Yeah.
Okay, and we've talked about itching as being quite a debilitating symptom. What can we do about that? Because obviously, like with Walt, you've described how he's itching at night.
Yes, so he completely denies it's him and says Mr. Nobody comes in the night and scratches him. The guidance suggests that you can use a sedating antihistamine at night. So they say there's no place for a non-sedating antihistamine at all in the treatment of eczema. So things that you would maybe be using for hay fever and stuff, but just a sedating one. So in adults, you could use something like hydroxyzine or even chlorpheniramine. And in children, it's chlorpheniramine. So in fact, I bought some of that yesterday and gave him his first dose. So we'll see how that goes over the next week or so. Yeah.
Yeah. There are other things you can do if itching is a problem at night, to do with wet wraps and dry wraps, but I think we come on to that later on.
Yeah, and things like cotton gloves as well. So, I mean, Walter's eczema is not that bad, but, with people who have very, very bad eczema, the eczema clinic sometimes gives them silk pajamas, special silk pajamas to sleep in, which don't irritate the skin, or they give them cotton gloves to stop them scratching, and also to help all the topical ointments to soak in. Yeah.
Okay. Right. So we've talked about steroids, we've talked about emollients and treating infection. Do you want to talk about how the steroids should be applied now?
Yeah, sorry. So we probably should have mentioned this before. So with the topical steroids, you're just applying them thinly, and you can put them on inflamed skin. And the way you determine how much you need is by something called the fingertip unit, which I'm not going to go into now, but I'll attach a document which explains quite clearly what a fingertip unit is and how much you need to cover how much of your body. And if you use steroid properly, then it shouldn't thin the skin. But you just need to be careful if you're using steroids for a long time on the face, around the eyes, and on lower legs, particularly on the shins in older people where the skin is very thin. Yeah. So what they've started doing very much, they have this motto in dermatology for eczema at the moment, which is get control, keep control, which I thought was probably quite a good motto for life, really.
Yeah, generally.
But what they say is that if you have a patient who's having a lot of flares, so that they are, you're constantly having to give them steroids and stuff, that what you should be doing, instead of just treating the flares, you should be using a steroid weekend regime. And you can do this for both adults and children. So what you get, say you're using betnavate. So you get the eczema under control with the betnavate, and once it's under control, you wean it down, and then you carry on using that betnavate in the areas that flare up, even if the skin looks normal, and you do that on Saturday and Sunday. I mean, it doesn't matter which days, you pick 2 days, but typically weekends are easiest for people to remember. And that seems to be working much better, rather than these patients constantly pinging and ponging between flares. And the evidence is that you end up using a lot less steroids doing that as well.
So how long would you carry on with that weekend regime? Is there any advice given?
I don't think there is, actually. That's really interesting. And it's only something that I feel has come out recently into general practice. The GPs out there may disagree with me, but it's only come to my attention, in the past few years. I'm not sure how many of my patients are doing it, but I think, I'd be tempted to carry it on for 6 months and then stop and see what happens. With any of these things, some people it will stop it and some people it won't. Yeah. Yeah, and don't forget, so people that are constantly having flares, particularly I find people that are having them on their hands, is it actually an allergy? Is it something that they're touching that's triggering it? And obviously in the UK you can send people off for testing for that, but quite often what I just say to people is, just think about what you're doing in your day. What could you be touching that might be doing this? And actually sometimes it becomes very obvious. Yeah.
Okay. Shall we briefly mention the bandages and dressings, or?
Yeah, it's not something do you know much about it? I never prescribe it.
No, it's certainly something I've only ever prescribed after a patient's been seen by the dermatologist and has said prescribe these bandages for nighttime.
Yeah, so people get trained in it, don't they, by the sort of eczema team. So certainly for very bad eczema or lichenification, which is from this repeated scratching we talked about, that you get treated with a steroid, and then you get these bandages with an ixomyl paste on and other substances on them, and you wrap them over the steroid. And so I think the idea is partly that it helps the steroid gets absorbed better into the skin and reduces the itch, and the bandages are protecting the skin.
So but trying to break that itch scratch cycle as well.
Yeah, I think. Yeah. And the other thing that I thought was quite interesting that I haven't done, I don't know if you've done this, Minnie, is that they talked about exudative eczema. I can't say that properly. So when the eczema is weeping, is to use potassium permanganate, and that's not something that I've done, but I might again start doing.
Yeah, it's something that used to be used very often, isn't it, in the past, as a treatment for things. So
yeah, it's quite expensive, because I've used it a couple of times for an ingrowing toenail for patients, and thought that's really quite expensive for what it is. But anyway, there we go. That's an aside.
Okay.
So we're doing all these things, and they're still not getting better. So what are we doing?
Then we need to consider referring to a specialist at that point. Because it may be one that the diagnosis isn't quite correct, or that the eczema is so severe, or that you've reached the comfort of your experience and of your treatments that you're happy to use.
Yeah. So what else can the dermatologist use if they're on the strongest steroid that is safe? What else? What
else is available? Well, you can. Some of the dermatologists use immunosuppressants sometimes if it's really severe, or other medications to modulate the immune system.
Yeah, so that's things like tacrolimus are immune modulators, and that's something I haven't prescribed in primary care, although I suspect the time will come when we're initiating it. But at the moment, I would wait for a dermatologist. Yeah. And the immunosuppressants that typically I see things called DMARDs being used, which are it's an acronym for disease-modifying anti-rheumatic drugs. So it's drugs that you would also use in rheumatoid arthritis. So the most common one would be methotrexate. So patients would be put on methotrexate or azathioprine to suppress their system. So
it's got to be pretty severe for you to be considering those.
Well, it's interesting. Well, you say that, but actually I've had patients with eczema that I didn't think was that severe, but that's actually the treatment that they've had, and it's worked incredibly well for them for a short period. Yeah. And then phototherapy, again, I don't think I've had anyone have phototherapy for their eczema, but I have friends who had it as children.
Okay.
So I don't know if that's gone out of vogue because of the risk, obviously, of sun exposure and cancers. Yeah.
Okay, and the other thing that might be looked into, or that you could look into, is allergies, which you've briefly mentioned before, when people can identify the causes themselves often. Yeah,
and they do allergy testing. But I mean, certainly with my son Walter, he's a million miles away from this, so it's just a question of me giving him the antihistamine so he's not scratching at night, getting the steroid on so the itch isn't there and we can reduce the eczema, and just not forgetting to put emollient on him when his skin is fine. And I think that's such a lesson for me. Unfortunately, it's taken a few cycles for me to learn it. As you go, you should never have a GP as a mother. Terrible idea.
So the prognosis of eczema is a relapsing course, isn't it?
It is, but actually, really interestingly, I don't think I've got the stats on here. Most children grow out of it. So something like 65% of children will have grown out of it by the time they're 16.
So keep moisturising until they're 16.
Yeah, and but I think also don't forget the psychosocial impact of this. So particularly in small kids, you're getting disturbed sleep patterns. When they're a little bit older, they're going to have reduced self-esteem because of this visible disease. Maybe they're isolated because they can't go swimming because it aggravates their eczema. And I think
so. It does have quite a large impact on your life in general.
It does, and I so for some reason that I have yet to understand, lots of parents are very nervous about using steroids on their children, and I say to them, look, the risk of you not treating the eczema is that they're not going to get good sleep, which means they won't grow so well, they'll have worse behavior, they won't do so well academically, their self-esteem will be affected. Or you could use steroids for 2 weeks, which would make them happier and you happier, and then that tends to make them feel a little bit more confident in that actually this is the right thing to do.
Yeah, so it's supporting them to make those decisions, to treat and keep on top of it. So I think there's often a lot of bad press about steroids, but as you say, if you use them correctly, then there's not really much of a problem.
Yeah, exactly. No, exactly. And with so many childhood diseases, it's much better for the child in the long run to be treated. Than to have these chronic skin changes. As we said, the prognosis, there's a tendency to gradual improvement in adult life. So hopefully Mr. Nobody will stop coming into my son's room and scratching his legs.
Let's hope so.
Fingers crossed.
Well, thank you for listening. And I know this is a bit of a longer podcast than usual, but we felt it was useful to do it in a complete form. If you have
Brilliant.
So any feedback, let us know.
Yeah, and any further questions, please post them on the forum. Thank you for listening and goodbye.
Goodbye.